Depression. A clinical and psychological overview. Depression, or major depressive disorder, is a common, recurrent, and potentially disabling psychiatric condition characterized by persistent low mood, loss of interest or pleasure, also termed as anhedonia, and a range of cognitive and somatic symptoms. The ICD-11 classifies it under mood disorders 6A70, emphasizing a disturbance in affect, cognition, and physical function. Clinical features of depression. A major depressive episode involves at least two of the core symptoms: low mood, anhedonia, and reduced energy, alongside additional symptoms such as disturbed sleep or appetite, psychomotor retardation or agitation, feelings of worthlessness or excessive guilt, impaired concentration. Suicidal ideation or behavior symptoms must persist for at least 2 weeks, cause significant distress or impairment, and not be attributable to substance use or a medical condition. Etiology and models of depression. Depression is multifactorial, with contributions from biological factors, neurochemical imbalances, notably serotonin, norepinephrine, and dopamine, dysregulation of the hypothalamic pituitary adrenal HPA axis, and genetic predispositions, e.g., polymorphisms in the serotonin transporter gene. Psychological models. Beck's cognitive theory emphasizes dysfunctional thinking and negative schemas. Learned helplessness of Martin Seligman posits that perceived lack of control leads to passivity and low mood. Attachment theory connects early life insecurity with later vulnerability. Sociocultural factors. Loss, trauma, chronic stress, and marginalization are critical social determinants. Assessment of depression. A structured clinical interview, complemented by validated screening tools such as the PHQ-9 or Hamilton Depression Rating Scale, helps in diagnosis and severity assessment. Importantly, comorbidities, such as anxiety disorders, substance use, or medical illnesses like hypothyroidism, must be carefully evaluated. Neurobiological correlates of depression. Neuroimaging studies often reveal decreased activity in the prefrontal cortex and anterior cingulate cortex, alongside hyperactivity in the amygdala, reflecting altered emotion regulation. Inflammatory markers like C-reactive protein and cytokines are also under study, suggesting a possible neuroinflammatory subtype. Management of depression. A biopsychosocial approach is most effective. This may include pharmacotherapy, SSRIs, e.g. fluoxetine, SNRIs, atypical antidepressants, and in resistant cases, augmentation strategies. Psychotherapy. CBT is first line, along with interpersonal therapy, behavioral activation, and for some, psychodynamic therapy. Lifestyle interventions. Exercise, sleep regulation, mindfulness, and social connection are protective. Somatic therapies. ECT remains effective for severe or treatment-resistant depression. rTMS and ketamine infusions are newer options. Course and prognosis of depression. While many recover from a first episode, relapse and recurrence are common. Early intervention, adherence to treatment, psychoeducation, and psychosocial support improve outcomes. In short, depression is not merely a disorder of mood, but a complex interplay of biology, psychology, and social context. A nuanced, compassionate, and evidence-informed approach is essential for diagnosis, treatment, and long-term care. For the medical professional, understanding depression through both the lens of clinical rigor and human empathy is the cornerstone of ethical and effective practice. So use this term sensibly. To know more, please call our psychologist at 88-475-21527.